Good afternoon, everyone. I know we're getting there to the final stretch, so thank you for hanging in there and continuing to keep the momentum, the excitement. Just when you think every conversation has covered everything, there is one more thing and one more thing, because that's how healthcare works and that's how we solve. I have so many notable quotes from today, like the fact that healthcare innovation is not just that, it's about integration. And I think this next panel is going to be a great example of that. So I am honored to be the moderator. For those of you that don't know me, I am Lili Gil Valletta, the co-founder and CEO of the Culture Plus Group, and we're proudly minority-owned and independent family of cultural intelligence companies doing a lot of this work to bring it all the way from research to strategies into the market, so we keep reaching more people and more places with solutions and marketing messaging that matters. But today we have two people. One is a great friend that I already know from many oh gosh, it feels like many moons before and ago. And a new friend, hopefully, Dr. Henry Ruiz. So let me introduce you, and please walk up to the stage as I say your name. Tony Quinones is the CEO of Bright Path Labs. I've had the great pleasure of really learning about his technology. We'll learn more about it, but truly a disruption in the way pharma manufacturing and really the way of manufacturing for the future of pharma and democratizing how we get active, APIs more quickly in more places so that we are not so dependent on the current very slow and cumbersome supply chains in the world of pharma. And we learned that the hard way kind of during the pandemic, which you and I were on the phone probably more hours than we want to admit every day during the pandemic. And then a new friend, Dr. Henry Ruiz, who's the chairman of the board for Renaissance Medical Foundation. I cannot wait for Dr. Ruiz to share with us more about some new models in care delivery and how we can get to patients to other places that I think, Dr. Henry, I think you don't look like a Lili Gil Valletta, but we'll confuse, or just stay there and we'll just see if they're paying attention. So yes, we'll learn more about some of the innovations, and the topic, as you see there, is how we go and reimagine solutions that go from lab to human, the manufacturing, the R&D, all the way to the care delivery when we're touching one person at a time, one community at a time. All right, so I'm gonna take a seat and let's give them a hand as we start this new panel. Thank you. All right. We're going to make this easy so the team or everybody here understands what you do, because I'm not going to try to explain it. I did my best there. But in a few minutes, and I'm going to start with you, Tony, then with Dr. Ruiz, tell us what is it exactly that Bright Path Labs is doing as a disruption, honoring the title of the panel, as an innovative way to disrupt the way we get medicines or healthcare from lab to human.
I'm trying to make this easy, and I'm trying to think. I've spent the last 12 years of my life between a physicist and a chemist, and I'm neither of them, and trying to interpret what it is that they've done via the data and the information. But in a nutshell, what it is we make small molecules. We make the ingredient, the actual medicine that heals you or cures you. And we do it in a very innovative way that is rarely done in this industry, if not done at all. And so we are using our technology to take medicines, manufacture them in a way, in locations that drive down costs in a green chemistry way, and hopefully transform the way medicine is delivered in the future.
Tony, just to give some perspective, on average, how big is a typical pharma manufacturing facility with batch manufacturing, which is the way things are done today? And of course, it takes a lot of infrastructure to be able to have those lines set up. So size and kind of manpower that it takes versus what Bright Path does.
Great question. About the size of a football stadium. Sometimes maybe even the size of a college football stadium in the United States, which is acres and hundreds of people. And what's really unique is we were in the good fortune to incubate our technology called an STT reactor that produces these small molecules in a size about of this room. In some cases, we can make the same volumes that a size of that facility with a dozen people compared to almost 80 people, and you're getting the type of purity, the type of quality that you would need to make FDA standard products. So it's a substantial cost savings just in the infrastructure alone.
There you go. So I wanted to give you some perspective. This is disrupting even the capital, investments of big pharma companies, and a lot of the pharma companies have outsourced that. Just again for perspective, about 60% of the APIs that we consume or need as active ingredients for our medicines in the United States we are dependent on China and India. And those manufacturing facilities are there. So if there is ever a way for us to onshore pharma manufacturing again and do it in a way that is cost efficient, that is made in the USA, that is compliant to the purity standards that you're mentioning, is with this type of technology that Bright Path Labs is bringing forward. So anyway, just putting it in context because it's big and different. Now, Dr. Ruiz, you are also innovating in a different way. And I would love for us to learn more about what is it that you're doing that is so different in that way of delivering care.
Well, first of all, I saw a lot of the lectures from this morning address global approaches to inequalities, national inequalities. We addressed it at a local level, and we tried to perfect that the system, and hopefully other peoples can benefit from that. So I am the chairman of the Renaissance Foundation, which just a quick explanation. In Texas, hospitals are not allowed to hire physicians directly, so there has to be an entity in between. That's the foundation. That's where I'm chairman from. We have about 275 physicians of all specialties and about 60 mid-levels, so it's a pretty good size. DHR Health is in McAllen, Texas, which people who are not from Texas probably never heard of it, but it's in Hidalgo County. Hidalgo County is one of the largest counties in Texas, but it's one of the poorest. It's 93% Latin. Now, that's to me, it's a privilege living there. So many years ago, about 25 years ago, there were two other health systems, for-profit, which were interested in that. The profits were very little interest in taking care of the community. So that was the driving force for DHR Health to be founded. And it was the vision of some very, very visionary local business and physicians that came together to try and address those disparities. I started as a very small surgery center. When I got there 22 years ago, it had just become a 30-bed hospital. Today, it's a 550-bed health system. All the specialties are represented. We even are a level 1 trauma center. We are a transplant. We do transplants. And as you can imagine, it's very difficult for us to recruit physicians to come down to South Texas. McAllen is 11 miles from the border, and that brings a lot of misconceptions with that. A fun fact is that McAllen is considered the third safest city in the nation. That's pretty good. So in any case, because of those limitations, we came up with the idea, well, if it's hard to recruit, why don't we develop our own graduate medical education programs? So we did. We became affiliated with the University of Houston School of Medicine. We now have residency programs in urology. I'm a reconstructive urologist by training, general surgery, internal medicine, family practice, and obstetrics and gynecology. We feel that, okay, and we're most interested in accepting and training those people that are more likely to stay with us. So one of the things that I ask my residents when I'm interviewing them is, in how many places do they get to be interviewed by people that look like them, who are like them? 0. It's always the same as 0. Anyway, we continue to progress. We're now applying for fellowships in GI, cardiology. So with all that in mind, so how do we address health inequities. So we agreed that we needed an expert. So we brought a health equity officer who then came and established this committee made of leadership from the hospital administration, community, and even the nursing staff in charge solely of addressing inequalities and put forth any initiatives that needed to be pushed. We then went ahead and established this very interesting, it's called a universal social determinant of health equity. It's a pretty important piece of the whole puzzle because it allows you to identify the different problems, needs, and inequalities in your own community and how to best address it specifically for that community. In 21st century United States of America, we found that the number one driving fear in our patient population is still food. The food insecurity was number one. So that led us to form a partnership with the local, the Rio Grande Valley Food Bank. So we were able to establish pantries all throughout the health system. And now we can provide food for about over 700 families a month just by doing that. But then we went further. We established what we call a patient family council so that we would bring patients to and met with us so we could hear what their concerns were and how we could do better if we, bottom line, did we screw it up? Can we do better? And so that also gave them a voice. It made us better because it allows us to concentrate on the things that they really needed. So following that, we said, well, what else can we do to improve things? So we came up with the idea of partnering with our family practice residency program. And we changed the curriculum so that it would include topics on health inequalities. We feel that if the next generation physicians are trained to deal with that, they'll be much better equipped to recognize it and then hopefully bring some solutions to that. So following that, we established this very interesting educational program that is health system-wide, that is in general about health inequality, but department specific. And again, everyone is aware, can recognize disparity, better address or bring it forth to the administration. We also instituted this, it's called it's a questionnaire that we're including all the admission in patients, which led us to identify the level of health education of each patient. If you do that, then you can direct the education to that patient for that level so that it's understood. If you come up with some complex explanation for someone who has really no idea what you're telling them, they're not going to follow the instructions. So we did that. We also included a questionnaire regarding gender identity. Now with a population has very specific needs and different issues that need to be addressed, so we are able to identify those and better address it with them. And then we have our crown jewel, is what I call a crown jewel. It's called the Hope Clinic. Hope Clinic is a clinic that we have that is staffed by some retired family practice and internal medicine doctor. That the sole purpose is to provide care for all undocumented patients that we have in the Rio Valley. That is a lot. And as you know, those patients wait until the last minute for the condition to seek care, and it's usually in the emergency room when it's really late. With this clinic, fully funded by us, they get free health care. It's like any prenatal care, all those things are included, and specialties from the health system go on a monthly basis and provide the care, and if they need any procedures, we make special arrangements so that if they need to have surgery, then it's a very nominal price. I usually don't even submit any charges for that, and the hospital is very conscious about those things. We conduct what is called Fishing for Hope tournament in South Padre Island. The whole purpose is to fund this amazing clinic. So we're very proud of that, and let me tell you, it is packed every day. When I go there, it's like going all the way to the streets, but it's very rewarding. Those are some of the most appreciative patients you can possibly have. So we've done it that way. We concentrate on the local and finding the needs of our community. Once we do that, we can talk about how else to spread that knowledge, and maybe can extend it. But to me, it's important to localize the needs. You might consider, in all your respective communities, find a health system that you can partner with and see if we can do something that is special, that can allow you to address your people.
Yeah, thank you, Dr. Ruiz. Just to kind of summarize, because there was a lot there. We heard, no, but this is really good. We keep hearing that 80% of health outcomes are driven by other things that are not medical care or treatment. That's the social determinants of health. Then we keep hearing over and over this thematic of personalization. Our scientific community is obsessed with personalized medicine. The panel right before us, Stephen and Melissa were talking about basically what arguably could be personalized marketing or targeting or messaging. And this is personalized care design and care delivery. In acknowledging, and nothing against the big healthcare systems, in Texas, whether it is Texas Health, Baylor, you name it, there are protocols, and maybe they are designed to the best, common denominator, one size fits all, yet for a community that is more than 90% Latino in a border town like McAllen, there was the need to redefine what that protocol or that care system ought to include, which is basically what you've been able to prove and have the results, the outcomes, the private funding around it. And that's why I was so excited when I learned about you for this panel, because to me, that's a glimpse of the models of the future for personalized care design. And I know that could feel overwhelming, because then how do you regulate it? How do you standardize KPIs? How do you do reimbursement? Anyway, we can figure that out. And I know we have Humana and Edna here, people here, they'll figure it out. Will help us figure it out together. But thank you, because I wanted to really put that in perspective of the complexity and the courage that it's taken for you and your teams to basically be open to rewriting the rules, all the way from how people are trained and recruited to the types of services that you're appending at the time of assessing somebody's health literacy levels or food needs. So that it's brilliant. I think that clearly shows us how we were feeling health equity gaps. And I'm wondering, Tony, for you, back to manufacturing and APIs and medicines, how is that this new agile way, let's say, or this innovation of manufacturing help in filling health inequity? Because this big number I said of the 60% from India and China, that's for everybody. All of us are impacted by that. But specifically, how do you see this with unique communities, countries? What have you seen with your work already?
So one of the things I always think about is personalized care means personalized medicine. So what's personalized medicine if those molecules aren't designed specifically for you? If you're an astronaut, maybe you're going to get millions of dollars of specific, very detailed type of treatment. If you're Joe Schmo or Jose on the street, probably not. And I think lowering the cost of the infrastructure of manufacturing is going to allow for more personalized medicine to be able to meet patient care needs. And I was recently in DC and heard $9 billion is the amount of infrastructure cost that's needed to get the United States up to par with manufacturing our medicines. And why I think that's a ginormous number, recently, I think it was a month and a half ago, we were announced that DARPA, the FDA, HHS are taking this very seriously. The need to onshore medicine manufacturing and drug substance manufacturing has taken on a new importance. And it's, yes, supply chain disruptions, but also our ability to take on the advancements of AI drug discovery and that rapid pace of personalized medicines being able to reach the patient. So those entirety of the supply chain is I think underway being overhauled, and we like to think well, I think we were right in the center of it. You can't get to personalized care if you can't have a personalized medicine. You can't make personalized medicine unless you have the drug substance. And most likely you're not going to get the drug substance unless you have chemistry, and that's what we do.
I love how you tied it together. Are there any use cases, Tony, of the stuff that you've already tried? I know you've done stuff in New Mexico. You're now in Texas as well. But any examples of bright spots for Bright Path in its work?
That gets me really excited because I think why we started the company in the first place was about orphan rare disease. It was my belief that there was more likely in the big grand scheme of things of pharma needing to drive budgets, that those were going to be the patients that most likely weren't going to get their molecules made. So sure enough, a friend of mine in New Mexico heard me complaining a bit, and he wrote a grant, got the grant for a distributed manufacturing strategy, which we received that funding a year ago. It allowed us through a LinkedIn message, I think someone mentioned, like, it's really powerful. A patient advocacy group out of Australia heard about us, and through Australia, that patient advocacy group of only 300 kids in the world have this disease. Now, the sad part about this disease is that the drug, Amlexnox, has already been made, already approved, but it really didn't have the dollars behind it. So they scoured the world, and I heard this dad, when we got on the phone with them, they asked us, can you make it? We literally made this drug for $6,000. We made the drug and contacted a group in Texas. They formulated the drug, prepared it, and we shipped it to Australia. We got on the phone, people from NIH and universities, all on the phone, and the most important voice was two of the fathers, one in the US, one in Australia, saying, thank you, thank you. We scoured the streets of Tokyo. Every pharmacy in Japan, we tried to find the remaining bits of this drug that the large company would no longer make. It literally took us, by the time we bought all the materials, made the materials, got it tested, it took us less than 2 weeks, $6,000. And I can give you story after story after story about actually how much it really costs to make a drug. Okay, it is, you blow your mind. And I think we have the good fortune of hearing that dad. It just resonates in my head all the time. It's like, that's the drive. That is that determination of why we do what we're doing. And I think I can just go on with stories after stories, but I think that's where I think about personalized care. And all over the New York Times, Washington Post were writing a story about carboplatin, cisplatin, a cancer drug that was in drug shortage. The reason why we started Bright Path, Wathohook. Wathohook is the name of our company. Wathohook is a name, it's a spirit. And that spirit is Jim Thorpe of the Sauk Fox Nation. And where I grew up and how I grew up, that became very important for us to look at constantly being overlooked, constantly just being discarded, and just said, you know what, we're going to have to fight. We're going to have to fight this industry. We're going to have to fight to get ourselves into the system, throw our elbows, out sprint, out jump, out hit, everything that we need to do to be able to get these medicines that are constantly and chronically on drug shortage for no other reason than really just gets down to dollars and cents. So we're not a nonprofit. We do want to make a profit, but do we have to make a 1,500% profit on a drug that is made for maybe $65,000, but a dose is $240,000? Absolutely not. So there's definitely a time for change and reform, and we want to be on the forefront of partnering with organizations like DHR and other hospital systems that service, I would say, pretty much the forgotten patient, often because it's just too expensive to treat them. And I think that's time for a change.
That's incredible. I think you're stretching our imagination and our brains here. You are mine, certainly. We think of health equity as the traditional construct of everything we've been talking about today. Systemic racism, implicit bias, maybe lack of access or health literacy. But what you just said is another form of health inequity, which has to do with access to active ingredients or therapeutics that are indeed available yet not manufactured because of commercial reasons. I hadn't thought about that, so thank you. Sorry, I'm just like real time telling you what's in my head. But brilliant. I cannot wait. I know that you will keep doing this and it will go places, and every pharma company is going to have to and want to partner up with you. But until we get there, final question, because I think we only have a few minutes, and I'm going to go to you, Dr. Ruiz, in a few minutes. Or in a minute or two, tell me, you close your eyes, is the year 2050. What is different in our healthcare ecosystem? What's your dream?
That what we do in McAllen is essentially extended to the rest of the world.
Oh, yes, yes. How about for you? Yes, let's give a hand to that. By the way, great field trip. I highly recommend it. I think we should all of us that claim to be in this space, need to go see those kinds of facilities in action.
Everyone is welcome.
So I'm inviting myself already.
Yeah, anytime. Last thing that I want to say is that every day I go to work, I know I make a difference.
That's beautiful. Yes. Tony, I think I know what you're going to say, but say it again. 2050, what's happening? What's that future of healthcare looking like for you?
Well, I do know we have to be data-driven, so I'm going to be working with people like Abigail EchoHawk to look at the data in native country, look at data in different zip codes, look at data in different groups, and personalize those medicines and make sure that the quality of the medicine can be manufactured right next to the hospital, right next to where the patient is going to receive that medicine, and ensure that there are not drug shortages, and most importantly, the outrageous prices that patients and families are forced to make. They just don't have to do it that way anymore.
I love it. So this gives me a lot of hope, and also adding to the panelists from earlier, from diagnostics that take one pinch and not a whole other, type of endoscopy, you name it, to care delivery that truly is personalized, and reimagining how we go all the way from manufacturing into personalized therapies and really impacting people. We can do this. I think we can. We definitely can, and we will. And when there is a will, and there was ever a willing party, was definitely the two of you as leaders and everyone in this room. So thank you so much for inspiring us. Thank you for the work you do, and for continuing to leave a dent, a good one, in the worlds that you touch and impact every day. Thank you.